really am excited. We have Shelley Haffner speaking tonight, and she is one of our graduates who we were so lucky to be able to stay in touch with. Shelley was in our program for a while, and then we were able to do some events with her in person, and we were able to go to some conferences with her. So whenever we did anything in the Penn State area, we always knew that we would see Shelley there, and it was always so great. So she graduated from Penn State with a BS in nursing, and she got her MPS in Homeland Security, Public Health Preparedness. Most of her career was spent working in outpatient healthcare settings. She retired from University Health Services, Penn State University Park, in 2020, with the last 13 or 14 years as the infectious disease manager, with the added responsibilities of staff education and liaising with Commonwealth campus health centers. During her time in the Public Health Preparedness Program, she researched and developed tools and training exercises for Penn State campuses. During the fall 2020 semester, she worked at the Penn State Altoona campus on COVID-19 response, including case management and contact tracing. Shelley is always an example that we use when we talk about your capstone. She was able to do her capstone and immediately roll it into the work that she was doing here at Penn State. So she was able to make an academic project into a practical application instantaneously, and it was she did an amazing job on it as a student, and then she was also able to use it in a really great way for the health services here. So she's always an example that I like to point to. So Shelley, thank you so much for coming and speaking with us tonight, and we look forward to hearing from you.
Thank you. I appreciate being asked to talk. I'm really pretty excited about this. When I was a student, I loved listening to these monthly programs. Tonight, what I'm going to be talking about is responding to disease outbreaks and just reviewing a little bit of the type of work that I did when I was working at Penn State. As Jen said, I was the infectious disease manager at Penn State. I worked at Penn State for over 25 years, but I didn't start in that field. It was one of those things that my position was being eliminated, so I needed to find something else to do to keep my job. So this is where I went with infectious disease management. And what I needed to do was learn and develop the role. I spent a year reviewing and writing procedures. During this time, UHS often moved to a new building, which necessitated new workflows and changes for clinical staff. And there were challenges. Anytime you're changing procedures, anytime you're changing workflows, you're going to get some resistance until people get used to it. From the staff, I would hear, we've always done it this way. I never had a problem before. Why change now? I don't have time for this. And if I'm only hurting myself, what difference does it make? It's my choice. For management, we don't have the budget for that. We can't spare staff for this. We'll think about it if it becomes a problem, and this takes too much time. Well, that was back when I first started. This hasn't changed. These are the same kind of challenges that we face today, too. But 2009 brought us the H1N1 influenza pandemic, and this was a biggie for Penn State, especially University Park, where I was working at the time. It affected young people more than the elderly, which is really unusual for influenza. Influenza typically hits the elderly hard, but it wasn't with this pandemic. About a third of the people over 60 years had some type of antibody response to the virus. And they think it was likely as a result of exposure to a similar virus in the past. And globally, 80% of deaths were people less than 65 years. When you consider who this was hitting, this was a big concern for university campuses, where the majority of students, faculty, and staff are under the age of 65. And in the fall of 2009, H1N1 spread rapidly across our campus. The pandemic had started in April, but we didn't get affected until really fall semester. We had a few cases during the summer, but in the fall, within 2 weeks of the start of fall semester, we were overwhelmed. Some of the challenges that we were experiencing then included lack of PPE. N95 respirators were in short supply, surgical and procedure masks, eye protection. There was a challenge of educating and training all UHS staff in new procedures that we were going to need to follow. We also had an inaccessible Penn State emergency plan. Now, Penn State did have an emergency pandemic influenza plan. However, this plan was not shared with me until after the pandemic, and only a few administrators at the health center even had it. Limited funding for additional help at the beginning of this pandemic was making it challenging and creating long hours for staff. And many phone calls were coming in from parents who obviously and understandably were very concerned, faculty, staff from other areas of the university, media calls. They were coming in on our triage lines. So it was making it difficult for us to actually talk to the students who were sick. I learned some lessons from the 2009 pandemic, and the biggest was we were really lucky. Although much of the student body became infected, we did not have any student deaths and very few hospitalizations. But by the time the vaccine began shipping to University Park, we were already seeing a decline in cases because this didn't start really shipping until towards the end of October, and we were already seeing that decline. And another thing I learned was we needed some kind of a plan, but that plan needed to be easy to communicate and understand. It must be accessible to everyone. And if the people doing the work don't understand or have access to your plan, it's going to be useless. Why even bother having one? And collaboration and communication are critical. So I found, a few years later, I found the Homeland Security and Public Health Preparedness. Now I had this idea, I knew that we needed something. I had no idea how to go about doing it, but I found the Homeland Preparedness, the Public Health Preparedness program online, thought it looked interesting, so I thought I'd try it out. Well, this was a game changer for me. I got hooked in the program, I found resources that I needed, and I went to a meet and greet that Jean was having, and we were talking about what we wanted to do, and I said, oh, well, I want to create a plan on infectious hazards because I think we need one. And that's when he suggested do it for an independent study. And that made all the difference for me. So why plan for infectious hazards? Why do that? Most places have emergency response plans, but why do we need something specific for infectious hazards? Well, one, early identification of an infectious disaster is going to afford better management and control of further spread. The planning is neither quick nor easy. An appropriate response is going to improve the safety for everybody. Response is rarely easy when you're talking about infectious disease outbreaks, but a plan really can make a difference. There were three questions I asked myself when I was making this plan. The first one was, what makes university communities so vulnerable? Why is there such a concern? Well, many reasons. Communal living. At the University Park campus, about a third of the students lived on campus in residence halls, so communal living. That meant 2/3 of our students lived in the State College community off campus in fraternity houses and multi-person occupied apartments. And these apartments could be anywhere from 2 people up to 7 or 8 people in one apartment. Our students also, several of them, work in the community because they need jobs to help pay their bills while they're students. Many of the jobs they have are working in customer service and in the food service industry. We also have classwork that would put our students at risk, including labs, group studies, and just large classrooms. Some of the classes at Penn State University Park are huge. We also had students, faculty, and staff that traveled internationally. We had students and faculty coming in internationally, and we also had people traveling to those areas. Anytime you travel to a different area, you have the potential for bringing a new pathogen into your community. We also had social activities. Penn State football is a biggie. Beaver Stadium holds over 100,000 people, and you also have tailgating and parties before games. You have it after games. It's a big social event. Also, Penn State Dance Marathon. I don't know if everybody's familiar with on, but it's the world's largest student-run philanthropy. Each year, third weekend in February, 15,000 people jam into the Bryce Jordan Center on campus, dance for 46 hours to raise money. They raise millions of dollars for Penn State Hershey for children's cancer for the Four Diamonds Fund. But third week of February is a big time. There's a lot of different illnesses circulating on campus by that time. And also, we were starting to see children of anti-vaxxers coming on campus as well. Now, not only were we seeing those students whose parents did not believe in vaccines, we were also seeing students that weren't vaccinated for other reasons, for medical and religious reasons. We also were seeing more immunocompromised students on campus than we had in past years. Because of medical advances, these students who normally would not have made it to college were now coming onto the campuses. So we had a lot of reasons why we were vulnerable. So the second question I needed to answer was, which infectious diseases are the biggest concerns for university communities and why? Well, ease of transmission of a pathogen. Pathogens of greatest concern are easily transmitted person to person. They're highly infectious. They cause severe illness, transmitted by multiple routes, remain viable in the air or on surfaces for extended time periods, and there's no treatment available. So if you have a novel pathogen, you're going to experience a lot of problems like we did with H1N1 in 2009, and certainly more like what we're facing with COVID now. Disease outbreaks have been occurring on university campuses for years. Just some examples were in the 1980s, measles, mumps, and rubella. They spread between universities. 2008, big norovirus outbreaks at colleges in California, Michigan, Wisconsin, resulting in more than 1,000 cases. Closed one campus for a while, campus population of 32,000 students, which when you're closing a campus abruptly, that is not a quick and easy feat. 2015 to 17, there were multiple mumps, measles, norovirus, and meningococcal disease serogroup B outbreaks on campuses. And my last question is, who are the key players or collaborators? Well, Penn State, prior to my working on the infectious hazards plan, had a group, the infectious hazards planning group. It had been in existence for quite a while. The purpose was to include critical departments and agencies in notification of an infectious disease concern that may affect the Penn State University Park campus, to allow for questions and discussion of response plans for the Penn State and State College communities, and to institute disease response community-wide. While membership on the committee, people would come and go on this group, it did include, for the most part, Penn State upper administration, emergency management from both Penn State and the State College community. You have to have academics involved and represented, global programs, international students, strategic communications, both for Penn State and for the center region, risk management, police services, human resources, environmental health and safety, housing and residence life, our local hospital, the state health department, and of course, university health services. So a lot of people, a lot of representation on this group. I met with the emergency managers for both Penn State and the State College community before starting this project to discuss it with them about infectious hazards planning, to create a plan as well as to do training. They jumped on board with this. They were very excited about it, and we worked together. We collaborated as a subgroup in developing plans and how we were going to work with this within the committee, within the group. So all IHPG members were eventually charged with creating their own departmental infectious hazards response plan. And then training began in 2016 as lectures, games, tabletop exercises, and they were going to be working up to drills. Well, did it work? Well, first off, I guess I should back up for just a minute and say the plan that I had created and done as classwork that I did with Jean, and we used at University Health Services and shared with Penn State Emergency Management, was shared with every member of the infectious hazards planning group so that they didn't have to start from scratch. They were able to take it, use whatever they wanted from it, make it specific to their own special department. So did this actually work? Well, actually it did. In the spring semester of 2017, Penn State University Park had a mumps outbreak. We had 87 confirmed probable cases of mumps, including 3 from Penn State Altoona. Case investigation found that social activities were the most likely reason for sustained transmission in one large cohort. Contacts were identified and notified. Individuals were isolated or quarantined according to CDC and Department of Health guidelines. There were approximately 800 contacts for the 87 cases. Just to put this in a little perspective, I was working on my capstone this semester. So did this plan work? Yeah, I'm not sure I could have made it without it. And also, with graphing information that was obtained, it also allowed me to take a look at where was mumps hitting and what kind of patterns were there. Well, once you put it on a graph, it was easy to see that the majority of cases were happening in our 20 to 22-year-old students. And characteristics that significant for them, they lived off campus. So they were living in apartments, they were living in the fraternities. At that time, spring of 2017, the fraternities were banned from having any parties for something totally unrelated to mumps. But that meant that the parties didn't stop. The parties just went to apartment complexes. And that's what happened with a lot of this and how a lot of the ongoing transmission occurred. It was through these off-campus parties. So what were some of the things, the advantages of the community approach? What was it that we actually gained from this? Well, we had improved understanding of who the key players were. When you have a disaster, it's nice, you need to know who the key players are, who's going to do what, because oftentimes you have to act very quickly with not a lot of assistance in the initial phase. Improved detection and containment of disease cases and prevention of additional cases. Improved collaboration between Penn State's University Health Services, the Mountain Medical Center, Pennsylvania Department of Health, and both Penn State and the State College Emergency Management. This was really significant. I can't emphasize enough the importance of collaboration and communication when you're dealing with infectious disease outbreaks. You're talking about a community. And when you're talking about universities, it's never going to stay just on the campus. It's always going to spread into your community because of the students living in the community and because of your faculty and staff who also are living in the community. With this training, we also had developed clear definitions of roles during disease outbreaks. So it really was very helpful for us for the mumps outbreak in 2017. So what I had wanted to do in 2017, I was also given additional responsibility of being the liaison to the health centers for an additional 17 campuses. Going to these campuses, it was apparent that obviously they were not Penn State University Park. They did not have the resources University Park had. Some of them were very small. So I wanted to try taking this training to these campuses as well. So the first one I wanted to try was Penn State Altoona. I reached out to the director to do a pilot program, and she jumped on board right away. After having 3 cases that were of months that were linked directly to University Park, she was more than willing to work with me on this. The background of Penn State Altoona is it's approximately 45 minutes drive from Penn State University Park. So students often travel back and forth to main campus for events and social activity. The student population there is approximately 3,000 students. Many of the students are commuters and live off campus. It's a different demographic than what we have at University Park, whereas many of these students at Altoona still may live at home. But with this, what we wanted to do is to get the information out. Just as we had been doing training at University Park, we wanted it at the campuses. So the first thing was I shared the plan from University Park with Altoona, asked them to take a look at it, to redo it, to make it for their campus. And then we looked at doing training. Once the kinks got worked out with Altoona, the training was initiated at other campuses. So phase 1, reviewing the plan. The plan was shared with the campuses, but I also did training on that plan with the campus health personnel. Phase 2, Penn State emergency managers and I collaborated to provide on-site training at several campuses. It was important to include emergency managers from these campuses because they were the ones that were responsible for response on their campuses. Also, you needed to, it couldn't just, when you have an infectious disease outbreak or a disaster, you can't have just your student health center that's responding to this. You need it needs to be a community approach, and it needed to be their campus community responding. So they were encouraged to include people within their community, emergency management within their community, state health department, same type of people that we would have had at University Park. Well, I ended up retiring February 1st of 2020. And if you remember back, that was right before everything hit with COVID. So I actually retired at a pretty good time. But COVID has created a lot of challenges. We first started seeing rapid spread in long-term care facilities. And why was it? Why did we see that in those groups? Well, communal living, age of the residents, compromised immune systems, delay in identifying and acknowledging the pathogen, lack of treatment measures, and delay in responding with public health measures such as isolation, quarantine, PPE use in some of the instances. This is not so different from other outbreaks that were occurring on university camp that had occurred in the past in university campuses. So it was just a matter of time before it was going to hit other places, and it did. Hospitals, outpatient treatment centers, clinics, private practices, prisons, schools, social events, gatherings, work sites. It was spreading like crazy. So what happened at Penn State Altoona? They had already gone through the training. They already had a plan. Well, their plan was in place before COVID hit, and they used it to initiate the response. The director of the Student Health Center there credited their planning and preparation for their successful ability to initiate a response to COVID-19. So they used what they had been given, what they had been trained with, and they initiated a response for their campus. However, as we all know, COVID overwhelmed many different places, including Penn State Altoona. They became overwhelmed very quickly during the fall of 2020. High infection rates, limited staffing made it difficult for them to work and to complete case investigations. Just to give you an idea, the staffing at Penn State Altoona at the Student Health Center, they had 2 full-time physician assistants, a full-time medical technician, no RNs, no LPNs, and a physician that went in and worked a couple hours a week in the evenings but did not see COVID. So pretty much it was 2 physician's assistants that were responsible for the whole COVID response for their health center, as well as treating other sick illness that students were coming in for. They were also doing testing in a tent that was set up outside the health center. So they had to go back and forth between the tent to do testing and seeing patients and making phone calls. Their funding they were funded to hire additional staffing late September of 2020. By then they had been working 7 days a week, 10 hours a day at least, and they were exhausted. But with additional funding, they were able to hire an RN who did testing, and they hired me back as an emergency hire to help with their COVID response. Health strategies that they had been using were masking and hand washing, limiting social gatherings, and part of this came through Penn State, case investigation and contact tracing, which they had done their best, but this is one of the things that I took over when I started for them. Isolation and quarantine. Vaccines didn't become available until 2021, so there wasn't a whole lot that they could be doing except monitoring their students. Case investigation and contact tracing is an important piece of public health response. Identifying positive and probable cases and obtaining a history of interactions during the infectious period can provide extremely valuable information. Obtaining a list of contacts, notifying the contacts, educating them about the symptoms and what they needed to do if they should get sick was also a key and important piece. When followed, the use of isolation for confirmed and probable cases and quarantine for contacts is an effective means to mitigate disease, in addition to other public health measures. And I say when followed because we didn't always have good compliance with this. Students that lived on the university campus, on the Altoona campus, yeah, it was easier to control whether they stayed in isolation or quarantine because they were being checked on and they had meals that were being delivered to them. But the off-campus, those students who lived off-campus, we found were not always following isolation and quarantine. If they were sick, if they were getting really sick with COVID, yeah, they stayed in isolation. That wasn't as big of a problem. But for those who had mild symptoms or were asymptomatic, it got to be a pretty big challenge. We had supply chain challenges at Altoona, lack of PPE for healthcare workers. This created less than optimal work practices, as you can imagine. Use of cloth, reusable masks was being done at Altoona. Reuse of disposable face masks and N95 respirators. Now, for healthcare workers, N95 respirators must be fit tested. They were not able to always use and fit tested N95 respirators because they weren't available, and they were just purchasing whatever they could get their hands on at that point. Alcohol-based hand sanitizers became scarce at one point. At times, gloves, gowns, and eye protection also became an issue. And then we had last fall unsafe fakes that were beginning to hit the market, whether it was in the N95 respirators or hand sanitizers that was found to be that were banned by the FDA. But trying to keep track of all of the changes that were occurring was very difficult for their staff. So again, that was one of the things that I was helping them with. There were communication challenges for Penn State Altoona, and these are not something that was just for Penn State Altoona. I think this was on a national scale. Lack of available science-based information made effective communication challenging. So when we had the new pathogen, there wasn't a lot known about it. It was best practices, what we knew. But as new research came in on COVID, it changed some of the practices. Trying to keep up with that became very challenging. There was also a distrust and disdain for information from science-based findings as it became available. Frequent changes in public health initiatives based on the research findings, and you're going to find changes. You're going to make changes to your recommendations once more information becomes available, but that also created distrust. And fake news that cast dispersions on individuals, public health measures, and health agencies certainly made communicating very difficult, both with the parents and with the students themselves, because they were hearing mixed messages. Incomplete, inaccurate, misleading information was really a biggie. Politicians, we know, were making, and still are, we're making decisions not always based in science, public health research, or public health practices. Some of the established mainstream media was reporting conspiracy theories, downplayed data, and reported inaccurate information. And social media provided an outlet to disperse inaccurate and harmful information and to facilitate the distrust of science. Collaboration became difficult. Politicians, both on the national and state level, got involved, impacted public perception and the ability of government agencies to report information. At one point, it was difficult being able to both report information, the CDC and Department of Health, and actually obtain accurate information from these agencies, which were always my go-to places. Collaboration between University and Park and Altoona was not as robust as it needed to be. Distrust of some of the top healthcare scientists and agencies hampered collaboration, and many of the health agencies, frankly, did not have enough personnel to handle the situation. This included the public health agencies, state and local health departments. This made it difficult to access. The Pennsylvania Department of Health they outsourced their case investigation and contact tracing for a lot of their COVID cases during the past year, making it difficult for those of us who needed to report. COVID is a mandated reportable illness. And for when you're working at Penn State, we were only working with the students. So we only reported the students through the Penn State system. But anybody that we were finding that was not a Penn State student that we knew about, we needed to report to the Department of Health. And it was difficult because there was not a consistent person that you could talk to. It was also difficult for many of the people to get information from the Department of Health. I was fortunate. I had worked, because of my years at University Park, working so closely with the Department of Health, I knew several people in the Department of Health and was able to get the information we needed. But it was difficult for those who didn't have those backdoor those opportunities. Staffing and availability of adequate staffing was a challenge for Altoona. They were, as I said, they were working extra hours, resulting in staff fatigue. Staff and their families were getting sick. Additional job responsibilities were being placed on them, and they had a lack of qualified staff. Normally, they had enough staff, but during the pandemic, they needed additional help. So what challenges do we still face? Well, after almost 2 years, it's going to be 2 years going into this pandemic, we're still seeing mixed messages. We're still seeing political leaders, government agencies, fake news, social media giving out mixed messages. Now, for those of us who understand the disease process, who are following the science, it can be challenging to be communicating that to people who don't understand it and maybe following some of this other information. We're also seeing individual rights versus public health. the individual's rights of it's my right not to wear a mask, it's my right not to be vaccinated, versus the public health that masking and vaccines have been shown to be helpful. We're still seeing supply chain shortages, not as much now as what we did a year ago. Fortunately, that has improved. But still with this pandemic, we were seeing supply chain shortages back in 2009 with the pandemic. Inadequate facilities, staffing, including coverage during absences of key players in units with limited staffing, trust in research and public health guidance. And this lack of trust is certainly making it difficult for communication of public health messages. When you're communicating public health messages, it's with the goal of positively impacting behavior. We're not always seeing that if people aren't listening and believing and trusting in what's being told to them. It's important to consider we continue to have many of the same challenges as in the past. Outbreaks may be over quickly or take months to years, depending on pathogen characteristics, available solution, and cooperation. Planning and flexibility in response will be important for the next epidemic, and there will be more epidemics. This is not going to be the end of it. It's just going to be a matter of what, when, and where. And in conclusion, responding to disease outbreaks is challenging. Advanced planning can facilitate faster response and mitigate disease spread. We need to learn from past and current disease outbreaks, and we need to act on lessons learned from successes and failures when we're preparing for future outbreaks. We could have done better responding to COVID-19, and we will need to do better with the next one. Thank you.
Shelley, thank you so much for that. Oh, I'll turn my video back on. So Shelley said that she would take questions throughout, and I actually forgot to mention that. I apologize. So if you've got any questions, either type them in the chat and I will read them out, or you can just raise your hand and I can see the participant list. So I will call on you and you can just speak your question. Savannah, go ahead.
Hi, great presentation. Thank you so much for sharing. I just have two questions. They're not related to each other at all. But the first one, I got excited when we were talking about tabletop exercises, and I was wondering how adaptable are those exercises to infectious diseases or agents that are used when we don't really have a lot of information regarding them. And then my second question, that is now escaping me. Oh, so also with behavior, there's also like risk aversions or how an individual perceives their personal risk for an infectious disease. Is that something that's also accounted for within communicating and developing these programs as well?
As far as your second question, yeah, you're right. How people perceive the likelihood that they're going to get sick from any kind of a disease, that does need to be included in the communication. What was your first question? I
was wondering how adaptable those tabletop exercises are to events that we may not necessarily have a lot of information about yet on the disease at the time or the pandemic.
I think you could, especially if you use the COVID, our current pandemic, as a kind of a guide. We knew a little bit about it before, and then trying to get the response. I think that you can do it whether you have a lot of information about the pathogen and what the disease is, what type of disease is going to create. I think you can adjust a tabletop to the information. You can also increase the amount. I mean, as you're going in your tabletop exercise, you can be adding more and more as you go along with it too. But I think it's adaptable.
Very cool. Thank you so much.
You're welcome.
Okay, we have a question from JD, and apparently it's loud in his house right now. So he says, you say, and I agree, that we need to learn from the past and current issues. Do you think that's really possible or even feasible? Politics and individual opinion being what they are. People are people after all, and memory is short.
I agree with that completely. And I have to say, for all of my years working in healthcare, I have never seen an environment like we've got now with people's opinions and the type of atmosphere we have now. Do I think it's possible to learn? Yes. And I think that, do I think that some of those mistakes are going to continue to be repeated? People being people, yes, I think they will. But we can also learn and acknowledge that we have issues. We can acknowledge the fact that communication, we've had a lot of mistrust in communication at this point. What can we learn from that? Well, going forward, definitely getting our messages out, we need to get, it's going to be difficult. There's never going to be an easy way to communicate during a disease outbreak, an epidemic, a pandemic. And yes, as long as we continue to have the type of environment we have, it's going to be challenging. But I do think that we can learn from our mistakes. I think that we can try new approaches. And I think we're just going to have to be willing to change quickly if the messages aren't getting out there the way they need to be, or people aren't hearing what we're trying to say. I don't have all the answers on how to do this. If I did, I'd probably be a mouthpiece for COVID and changing communication and collaboration right now. But I do think that we can change. As far as looking at supply chain, we had problems, supply chain issues back in 2009, and some of us are the same things, at least at Penn State's campuses. They had the same thing. They couldn't get the PPE. We shouldn't have had that. We should have been able to get get the supplies to the people who needed them at a faster rate. Hopefully I answered your question.
All right, we got a thumbs up from JD. Gene has his hand raised.
Shelley, great presentation and work. Thanks a lot. As always, yeah, it's great to hear the follow-up here. So I want to dig in a little deeper on the Penn State situation here, and you can pass if you want to pass on the question, but I have a couple parts. One is, so when you were reporting from Altoona, did everything have to go through University Park to the Department of Health and vice versa? So was University Park acting as a central hub, or did you communicate directly with Department of Health? And the second part of this question has to do with research. So at University Park, there was a fairly large initiative, Data for Action, that was put into place with a lot of surveys and blood draws from students as well as community members. So was Altoona involved in that? Were they offered the opportunity to participate in research projects?
To the best of my knowledge, Altoona was not offered, was not given that opportunity. As far as the reporting of cases to University Park, yes, positive cases, students that were quarantined and students that were isolated were put in through an electronic system that went directly to University Park. As far as long as they involve students. But with Altoona, we saw a lot of the students, because they lived off campus, because they were commuters, they were identifying non-Penn State related people. So those people needed to be reported directly to the Department of State. They didn't go through University Park as the main hub.
Mm-hmm. So is that communication with University Park generally good?
It could, as far as reporting the cases, yes, it was. Yeah, the part that was more difficult was the decisions being made at University Park didn't always translate well to the campuses.
Yeah, we still experience that. Yeah.
Yeah.
Yeah. Yeah. Thank you.
Mhm.
All right, Jenny, you're up.
All right. Thank you so much for your presentation, Shelley. This was so informative, and I'm glad to see another, I guess, viewpoint of everything that's kind of happened within the past 2 years. So I guess my question to you is, whenever you were doing your capstone and you're introducing this idea of an infectious disease surveillance type program, how did you get buy-in for all of this and to implement these plans and to get so many? Because you did mention there's a lot of stakeholders involved, a lot of roadblocks in terms of this is the way we always done it. So I'm just curious how you kind of overcame those obstacles as they came about.
Well, first off, I was extremely persistent, but I also, I contacted the stakeholders. I worked with, like I said, the emergency managers from both Penn State and the State College community. I had gotten on board with them, and it was actually after I had met with and talked to Jean about starting doing an infectious hazards plan. I had contacted the emergency managers because by that time I figured out what an emergency manager actually did, which I didn't have a clue of before I started the program. But I brought those people in, and they brought in, and I also had my boss, who was the senior director of University Health Services. So she was on board with it. The emergency management was on board with it. So we created the subgroup. It was easy when we were talking about infectious diseases because the group had met and we had talked about other potential diseases of concerns. We were concerned at one point of MERS, COVID that was in Korea because the students coming from Korea, South Korea. We also, when Ebola, when they had the outbreak in West Africa, we were concerned about that. It was easy to get risk management and some of these other groups on board. They were very supportive of doing a program like this. So once they came on board, using them to help generate some within the Penn State community to generate some interest in it became easier. As far as University Health Services and with clinical workers, a lot of them had been there during the 2009 influenza pandemic. So they were dealing with other potential concerns. So most of them were pretty eager to learn what they could do so they didn't have to go through another 2009 pandemic. So it was not a very difficult it wasn't difficult to get people on board at that point. You just have to know who your key people are that will help influence.
That's great. Thank you so much.
You're welcome.
Okay, does anybody, I'm looking for any more hands up. Does anybody have any other questions? I don't see anything in the chat.
So I'll ask one more if I can, actually, before I leave. Thanks, Shelley. So I guess I'm just wondering, you mentioned contact tracing. So, there are some folks who are saying that contact tracing really is not very effective once you get to a certain level, and it's a fairly low level of prevalence in the community. So do you have any reflection upon the effectiveness of contact tracing in any of your experiences here? I mean, what kind of measures do you use to know that it's actually working?
The contact tracing, as far as contact tracing for COVID, when I was at Altoona campus, yeah, I don't think was overly effective because you had to quarantine students. Some of these students were being quarantined 2 or 3 times during the semester. So there was constant transmission. During the mumps outbreak in 2017, quarantine was a bit more effective because we were seeing quite a few of the students that, I shouldn't say, there were 800 contacts, so no, not all of them became ill. But of the 87 cases, approximately a third of them had been contacts and had been in quarantine and had become, when they developed the mumps. So quarantine I think it can be effective. I think it's going to depend on what the pathogen is, and I think it's going to depend on just how quickly it's spreading.
Yeah, I agree completely. I think I think I've seen some folks, there's a lot of different opinions out there, but I think I've seen some folks say that once we get with COVID, once it's gotten to sort of the 2 to 3% population, the contact tracing is going to be of limited value because of its R naught value and its transmissibility, essentially, that it just overwhelms the system.
Yeah, the one part of contact tracing that I feel is helpful is the education that's being provided to these people, that they're being notified that they have been exposed and educating them on what to do if they should become symptomatic. I think that was one of the most positive things in the contact tracing at Altoona last year.
Yeah, that's a good point about the education along with the tracing. Good, thank you. I have to run to a family meeting. Thank you very much. I'll let Jen finish up here.
Okay, bye,
Thank you.
Jean. If anybody has any more questions, I'll keep an eye on the chat and I'll keep an eye on the participant box. I just have one kind of like unrelated question, but we do get questions a lot about capstones and independent studies and things like that. So can you just briefly speak about that? Like if there's any advice that you wish that you had gotten at the beginning of your independent study, or if there's any advice that you learned that you could give to a student who is looking to pursue a project like this, do you have any like words of wisdom that you can share?
I can share from my personal was that when I had that meet and greet with Gene after one of those programs in State College that we all went to, and for him to ask what I was working on and to say that would be a good independent study, it was like a light bulb went off, because yeah, it could be an independent study, whatever it is you do, linking an independent study to your capstone like I did really was helpful, because there was no research on infectious hazards planning. I couldn't find anything. So was doing my own research, and it was just, it was a topic that was something that I felt strongly about. I had been through a pandemic. I had been through a lot of disease outbreaks on campus. So finding something that really speaks to you, something that's really important to you, is really what you need to go after for the capstone. And I know I was one of those people at the very beginning. I thought, capstone, what in the world am I ever going to do? How am I ever going to figure this one out? But it was just one of those things, like I said, talking to Gene, and he said, why don't you try doing that one? And getting a tremendous amount of support from Gene and from a few of the other people like you, Jen, in the program, made it a lot easier to do.
Oh, thank you. We try, we really do. So Shelley had mentioned a couple times about the meet and greets. So for those of you that are, I want to say like COVID on in our program, so we would try, we would always get together at commencement, but we would also look for other opportunities that we were able to do something either in University Park or Hershey. And it could be something as simple, like there was a terrorism conference that had a kind of a bio spin on it about a year or two ago, or about a year or two before COVID. And we would do a meet and greet after that. And there were just a couple other times where things fell together, and we would always do, at least offer meet and greets. We had like a faculty retreat where all of us faculty members were going to be there. So we did like lunch. We just had an open lunch where people could come and meet us if they wanted. And they just, kind of spurred these like impromptu little conversations like the one that Shelley was talking about where it ended up leading to her capstone. So that's definitely something that we really enjoyed doing and something that we want to get back into once we can do it safely. So I don't see any last minute questions. So just as another reminder, we're going to be doing this again in a few weeks on December 1st. I mentioned the November 16th IAEM meeting, and as you heard from Shelley about the intersections again between emergency management and public health preparedness. So Shelley, thank you so much for speaking with us tonight. And it was great to see you again and to hear about all of your experiences. And I don't know if you can see the chat also. I did want to tell you before you go that Jean did say, great presentation and work. Wow, you are a hero to have stepped back into the arena after starting a well-deserved retirement. Thank you. So thank you so much for coming and yeah. So thank you so much for coming and speaking with us tonight. I appreciate it.
Thank you for having me. I really appreciated it.
Yeah. Well, we hope that you have a great night, and we hope everyone has a good night and a great month, and we will see you in just a couple weeks.